This is the pulmonary artery, and three components, one apical component that this is triangulated inside, this is the outlet, and this is the inlet. Although we can use the three component, the apical component, you can see that the apex belong only to the left ventricle. This is the left ventricle, you can see. This is the sternocostal view, and my right hand is the, imagine that this is the diaphragm. Therefore, this is the inferior view, because the heart in attitudinal orientation in this way. This is anterior, this is posterior, and my hand is the diaphragm. Therefore, all this area is posterior, but the area that corresponds to the inferior interventricular groove is diaphragmatic surface. Therefore, we have two surfaces. One is the area that corresponds to the sternocostal view. This is the right ventricle, this is the left ventricle, this is the apex. And please note that in this attitudinal orientation, 2/3 correspond to the right chamber and 1/3 correspond to the left chamber. Because the left ventricle is not only left, but if you can see, is lateral. This is lateral, lateral, and inferior. When we see this human heart from a posterior view, from this inferior view, you can see that this is 50 and 50. The right ventricle and the left ventricle. Therefore, from anterior view is 2/3, 1/3, but from posterior view is 50 and 50. Here, you are going to visualize the AV groove. This is the atrioventricular groove. This is the right atrium, and this is the left atrium. Please note that this is the right coronary artery descending through the inferior or so-called posterior interventricular groove. Therefore, AV groove, left AV groove, right AV groove, posterior interventricular groove, and here we are going to see the interatrial groove. This is the area that corresponds to the close of the heart. You can see that this is the base of the heart, the base in diaphragmatic position, the base of the heart. Let's go again in this specimen, and you can see from superior view, you can see the superior vena cava. This is the aorta, and note the pulmonary artery. The pulmonary artery is anterior to the aorta, and the aorta is anterior to the superior vena cava. And what are the more anterior structures of the left atrium and the right atrium are the appendage. This is the left atrial appendage, and this is the right atrial appendage. As you can see, both appendage are over the right and the left coronary artery in the AV groove. Please note here the AV groove. This is the right coronary artery, and this is the right AV groove. Can you focus here? This is the right AV groove. Please note all the area of the right coronary artery and the descending artery through the posterior interventricular groove. Then, as you can see here, the form of this border is acute. The right border is acute, and the left border is obtuse. You can see that this is obtuse. For this reason, we use the term obtuse bordered and acute bordered. And all the branches of the right coronary artery, through this bordered, these are the acute marginal artery. You can see that these are the acute marginal. And if we focus again in the right ventricle, you can see that this is the pulmonary artery. This is the infundibulum or the conus. All this area correspond to the infundibulum. And please note this small artery here. This artery are the infundibular artery or the conus artery. Here you can see the origin of the right coronary artery. If we focus here, note the origin of the right coronary artery. This is pulmonary artery. Please note the orientation of the pulmonary artery crossing in relation with the aorta, from right to left, from left to right, the aorta. And here you can see the origin of the right coronary artery. And note here the artery of the infundibulum or the conus artery. Here you can see the right coronary artery. All these area correspond to the right AV groove. And the right AV groove is surrounding the tricuspid annulus. This is the epicardial aspect of the right AV junction, the epicardial aspect of the right AV groove surrounding the tricuspid annulus here. And let's go here. You can see the right atrial appendage. This is the superior vena cava. And here we have the inferior vena cava. In attitudinal orientation, this is, here you can see the superior vena cava and the inferior vena cava. Note, here is inferior and this is superior. Therefore, all this area epicardially is the right atrium. You can see the right atrium. And please note this groove. This is the terminal groove. You see this terminal groove between the superior vena cava and the right atrial appendage. This is the area that corresponds to the synod nodal regions epicardially located. All this area endocardially, we are going to see this endocardially, correspond to the terminal crest. Endocardially, from superior to inferior, you can see the superior vena cava, the inferior, the area of the synod node, this between the right atrial appendage and the superior vena cava, and inside endocardially, this area we are going to see the pectinating muscle. This is the area that is going to separate the smooth walled area and the trabeculated area. Please note that I am going again, and this is the area that corresponds to the right AV groove, and the tricuspid valve annulus is going to be inside. Let's go again. Let's go again to the left side. And here you are going to see the origin of the, here, this is the aorta. You can see the circumflex artery. This is the area that corresponds to the circumflex artery. And note the left main and the anterior descending artery through the anterior interventricular groove. Here you can see this diagonal. And please note the septal branches of the anterior descending artery. Here you can see this is the apex. And in this heart, you can see that the posterior descending artery arises from the right coronary artery. Therefore, in this heart, the dominant coronary artery is the right coronary artery. Here, this is the area that corresponds inferiorly to the so-called inferior paraseptal regions. Let's go again. You can see here this artery. This is the circumflex artery. And you can see the left atrium. We have removed the pulmonary vein in this specimen. And in this case, you can see this artery arising from the circumflex artery. Here, you can see this artery running through this area. And all this area correspond to the so-called transverse sinus of pericardium. Please note this artery running through the transverse sinus of pericardium through the area between the superior vena cava and the right atrial appendage. And this is the area of the synod node. In 20–25% of the cases, the synod-nodal artery arises from the circumflex artery, not from the right coronary artery. The right coronary artery is the main artery that goes through the area of the synod node. But in this case, you can see that the synod-nodal artery arises from the circumflex. Okay. Let's continue with the epicardial aspect of the human heart. You can see here that this area for electrophysiologists is the area that corresponds to the so-called left ventricular summit. Here you see that this triangle corresponds to the area which you can see the bifurcation between the anterior descending artery and the circumflex artery. If we go to a new specimen, in this case, you can see again the pulmonary trunk, the aorta. Let's go again here superiorly. And in this specimen, you can see that this is the left atrium. Please note that this is superior, this is the dome. And you can see here a common ending for both the left superior and the left inferior pulmonary vein. This may happen in 20% of the specimens, and when we are doing electrophysiological study, we can see the presence of this common trunk, common ending of both left superior, and the left inferior pulmonary vein. Again, let's go here, and you can see the superior, right superior, and the right inferior pulmonary vein. All this area corresponds to the left atrium. You can see the left atrium epicardially. This is the left atrial appendage. You can see the left atrial appendage. Let's go again to see the morphology, the epicardial morphology of the left atrium. All the atrium, the common ending, the left atrial appendage, posterior view, anterior view. If you go posterior in this specimen, you can see again the left atrium, the right atrium, and note here that this is the right coronary artery, this is the right AV groove, and this is the left AV groove. And please note here and here, this is the coronary sinus. And this is the posterior interventricular groove. And here you can see the middle cardiac vein and the right coronary artery with the posterior descending artery. This is the cross of the heart. This is the complex anatomic regions of the so-called inferoparaceptal region. Some electrophysiology use the term posteroseptal region, but you will know that this is not septal, this is inferior and paraseptal region. This is the cross of the heart. Here we are going to see the AV nodal artery. The AV nodal artery go inside to the so-called central fibrous body to identify, to reach the compact AV node. Again, you can see here the coronary sinus, and please note that the limit of the coronary sinus with the great cardiac vein, this is the great cardiac vein, and from here to here is the coronary sinus. This is the Marshall vein. This is the Marshall vein, and the Marshall vein go between the left superior pulmonary vein and the appendage. This is the left-atrial appendage. This is the main lobe of the appendage. The orifice inside of the appendage is here. This is here, and this is the so-called landing zone epicardially for to implant endocardially the watchman or implanter to close the orifice of the left atrial appendage. Again, let's open here, and please note this beautiful view where you can see the anterior descending artery, and in this case you can see the great cardiac vein. Please note that this is the great cardiac vein and this is the circumflex artery. Therefore, this so-called left ventricular summit, that it is for interest for electrophysiologists because some ventricular tachycardia may arise from these regions, has these anatomic determinant. Please note the main, the left anterior descending artery, the middle cardiac vein, and the circumflex artery. Again, in this specimen, what we are visualized, this is the epicardium, and we have removed the epicardial tissue. If we see in, for example, in this specimen that we are going to open, this is the epicardium. And you can see the fibrofatty tissue of the epicardium. Here, we are not able to see the coronary artery like in the other specimen because we have removed the epicardium. And the epicardium, if we analyze what is the epicardium, because we have the endocardium, we have the myocardium, and we have the epicardium. The epicardium, in fact, is the visceral layer of the serous pericardium. Can you focus? The visceral layer of the serous pericardium, because we can identify the endocardium, the myocardium, and the epicardium, visceral layer of the serous pericardium, and we have the parietal layer of the serous pericardium and the fibrous pericardium that has been removed in this specimen. Therefore, the pericardial space is between this epicardium, that is the visceral layer of the serous pericardium, and the parietal layer of the serous pericardium. If we remove the epicardium and the fibrofatty tissue of the epicardium, we can see this sternocostal view, and we can visualize the coronary artery and coronary vein. Okay, let's go now to this very interesting area, that this is the transverse sign of pericardium. Please note that this area, this is the left atrium, the left atrium, this is the right atrium. You can see in this specimen all the right atrium, the right atrial appendage, the groove, the superior vena cava, the right superior pulmonary vein, the inferior vena cava, the right inferior pulmonary vein, and note how is the close proximity between the right superior pulmonary vein and the superior vena cava. And this is important for electrophysiologists because as you can see here, if we focus here, we can see myocardial tissue extending over the wall of the superior vena cava. Sometimes we need to isolate the superior vena cava in those patients with extra pulmonary vein foci for atrial fibrillation. Please note that this is myocardial tissue, and also please note the myocardial tissue extending through the wall of the right superior pulmonary vein. And these, many times when we are mapping inside, they may create far field potential because we are in this side of the left superior, the right superior pulmonary vein or the superior vena cava, and we may record electrogram from this because you can see that anatomically this is the position between the right superior and the superior vena cava. In this projection, also, please note that the transverse sign of pericardium can be seen here, and all these structures that can be seen here, all these structures correspond to the Bachmann bundle, the epicardially located Bachmann bundle. This is the main muscular interatrial connection between the right and the left atrium. And here you can see the left wall extension here and the right wall extension of the Bachmann bundle. Left wall extension and right wall extension. And here you can see how the Bachmann bundle grows surrounding the area of the left atrial appendage, superiorly and inferiorly, This left wall extension of the Bachmann bundle is crucial because if you go here, you can see the Bachmann bundle here. This is the pulmonary vein. You can see the Bachmann bundle. Please note its anatomic relationship with the ligament of Marshall. And as you well know here, the ligament of Marshall is in close anatomic relation with the postganglionic sympathetic fibers and preganglionic parasympathetic ganglion of the parasympathetic system. All these are in this region of the epicardial aspect of the left atrium. Here you can see that this is the area epicardially between the left pulmonary vein in this common ending and the appendage. This is the area epicardially that corresponds to the so-called ridge. We are going to see this ridge in the endocardial aspect. If we go to this specimen, please note that this is the left atrial appendage, this is the left superior pulmonary vein, this is the left inferior pulmonary vein, this is the area that corresponds to the left wall extension of the Bachmann bundle, this is the left atrium, and these that correspond to this area, okay, this area, please note that endocardially, if we go endocardially, correspond to the so-called ridge. You can see that this is the left atrial ridge. This is the orifice. You can see that this is the orifice of the left atrial appendage. You can see the pectinating muscle. Note the left atrium. We are going to back to this specimen just to visualize the left atrium, but I want to show you how this area of between the left superior pulmonary vein and the area that corresponds to the orifice of the left atrial appendage, this is a fold of the lateral wall of the left atrium. You can see the thickness is the same thickness. And if you can see where my finger, my finger is in the ridge, in the left atrial ridge. Therefore, this is not a ridge, in fact, this is a fold of the lateral wall of the left atrium, from superior to inferior and from anterior to posterior. You can see the left wall extension of the Patchman bundle. Okay, let's go again to the AV groove, and just to understand the anatomic relation of the right AV groove, the left AV groove in relation with the pulmonary artery and the pulmonary vein. We're going to a drawing here, and note, okay, this is the pulmonary artery, this is the aorta, mitral, and tricuspid annulus. This is short axis. This is a section through this level, just to visualize from this point. Okay, this is anterior, this is the pulmonary artery, this is the aorta, okay, this is the appendage, and this is the appendage. In the drawing, we have removed the appendage, and here you can see this is pulmonary artery, this is the aorta, and here this is the mitral annulus, and here you can see the tricuspid annulus, mitral annulus and tricuspid annulus. Then, in the drawing, please note that this is left, this is right, and this is not. Therefore, this is an important issue that we need to understand. The sinus or the coronary cusp, the left, the right, and the non. The non is posterior. And here you have anterior, left, and right for the pulmonary artery. Then, the first point here, you can see the right coronary artery surrounding the tricuspid annulus. This is septal, this is anterior, and this is posterior. This is anterior or aortic because it's in close anatomic relation with the aorta. And this is posterior or mural. Then, if we want to take in our mind the commissure and the papillary muscle, this is anterior and lateral. This is anterior and this is posterior or inferior. This is anterior and lateral, and this is posterior and medial. Therefore, this is anterior and lateral, and this is posterior and medial. And here we can see septal, anterior, and posterior papillary muscle. Therefore, we are going to see in the specimen an anterior and lateral papillary muscle, a posterior and medial papillary muscle. We are going to see this area, and this is the circumflex artery. In this case, with the circumflex artery, please note that this is the AV nodal artery through the area that corresponds to the his bundle recording site, and here we can see the coronary sinus, the area that corresponds to the coronary sinus. The coronary sinus, when we go here, 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 this is the great cardiac vein, and this is the area that corresponds to the left ventricular submit. This is the anterior descending artery, and this is the circumflex artery. This is the right coronary artery. Then, this is the short axis, just to understand how is the AV groove, the coronary AV groove. And this is crucial for electrophysiologists to understand how is the anatomy of this coronary AV groove. And please note that we are going to see some important anatomic regions that are of interest not only for electrophysiology but also for cardiology. And this is one area that corresponds to the mitro-aortic continuity. And if you see here, the mitro-aortic continuity is connecting two trigones, one and second trigones. This is here, here, and here. Therefore, this is mitro-aortic continuity, and this is left fibrous trigon, and this is right fibrous trigon. Right fibrous trigon and left fibrous trigon. All this area correspond to the fibrous skeleton of the heart. This is the annulus surrounding the mitral annulus, surrounding the AV groove. This is the tricuspid valve annulus. Usually this is not so complete surrounding the fibrous tissue. And this is the area here that corresponds to the membranous septum. The membranous septum. Membranous septum. Therefore, what is the area between the, here that we can see, between the membranous septum and the right fibrous trigon? This is the area where the His bundle penetrate. This is the area that corresponds to the central fibrous body. To know and to recognize the central fibrous body is essential, is crucial for cardiologists, because this is the area where the AV nodes penetrate, and it's completely surrounded by the connective tissue of the central fibrous body, and then is when we use the term His bundle. Please note that this is the vestibule of entrance to the mitral and tricuspid valve, and this area corresponds to this area in the specimen. This is the area here. This is the right coronary artery. If you go to the right coronary artery here, you can see this area corresponds to this area. And here, if we see the heart in this position, this is this one. This one. If you can see that this is the pulmonary artery, and this is the aorta. This is the pulmonary artery, and this is the aorta. Then, from here to here, we are going to have the AV nodal artery, and this is the cross of the heart. Therefore, this is the cross of the heart. And if you see this area of the cross of the heart, this is epicardial tissue. We are here out of the heart, as this is the so-called inferior pyramidal space. To recognize this inferior pyramidal space is crucial for electrophysiologists, because as you can see in electrophysiologists, this is the area that corresponds to the so-called inferior paraseptal regions. This area is not posteroseptal, it's inferior paraseptal region. And it is crucial to recognize that we should use the term inferior, left inferior paraseptal regions, or left inferior or right inferior paraseptal region to the accessory pathway or to the area that we are mapping here. And here we have also the middle cardiac vein. Middle cardiac vein, the orifice of the coronary sinus, the AV nodal artery, and all these areas fibrofatty tissue of the inferior pyramidal space, and the vertex is this, the membranous septum. The vertex is where the His bundle is penetrating. Then if we go to the specimen here and we try to visualize the area of the inferior pyramidal space, please note here, this is the base of the inferior pyramidal space. This is the base of the inferior pyramidal space. Then let's try to go endocardially to the component of the right chambers, the right side chambers. Here we are going to see the simulated right anterior oblique projections. Please note that this is the aorta, and here you can see the area that corresponds to the outlet component of the right ventricle. This is the inlet component of the right ventricle, and this is the apical component. This is the outlet, this is the right ventricle outflow tract, and here you can see the septal leaflet of the tricuspid valve. Remember that we are going to see the septal leaflet of the tricuspid valve, the anterior and posterior. And here we have opened the right atrium to visualize the main anatomic structures that are of interest for cardiologists and for electrophysiologists, that are the regions of the right atrium and its anatomy landmark. Remember that this is the inferior vena cava, this is the septal leaflet of the tricuspid valve, this is the AV junctions. Here you can see the Eustachian valve, the Eustachian ridge, and here you can see the area we focus that intramyocardially correspond to the tendon of Todaro. And here you see the area of the triangle of Koch, the septal leaflet, and this is the Eustachian valve, the Eustachian ridge, and all the area that correspond to the slow pathway, the area where we perform ablation in patients with AV nodal reentrant tachycardia. And this is the pouch from anterior to posterior. This is the so-called cavo tricuspid isthmus. Two regions in this specimen, the regions of the triangle of Koch, the region of the cavo tricuspid isthmus. The region of the triangle of Koch, the septal leaflet of the triangle of the tricuspid valve. This is anterior, and this is posterior. This is the anterior. Inferior, the orifice of the coronary sinus and the vestibule of entrance to the tricuspid valve. This is the vestibule. And posteriorly, the tendon of Todaro and the Eustachian valve. This area, if we perform trans-illuminations, let me just a second. Probably you can see here. Okay, just a second. Okay, you can see in this transillumination here. No, no. This is the area that corresponds to the membranous septum. And this is the area where the His bundle penetrated. This is the septal leaflet. This is the tendon of Todaro, the orifice, and all this area is the area of the triangle of Koch. The AV node, the compact AV node is here, and the His bundle penetrates through this area. That this is the membranous septum. This is the membranous septum. And this membranous septum and penetrate, and we are going to see the area okay, the area of the supraventricular crest. If you see in this specimen, this is the aorta, and the aorta is protruding into between the inlet and the outlet, and this is the so-called supraventricular crest. This is the right coronary artery, and there, this is the ventricular infundibular fold, and this supraventricular crest is between the pulmonary valve and the tricuspid valve. Therefore, here in the left side, we have the mitro-aortic continuity, but in the right side, we have the infundibulum, the supraventricular crest between the inlet and the outlet. There are not continuity between the inlet and the outlet. This is the supraventricular crest, and here you can see the pulmonary valve. We are going also to define this, trabeculation. Please note here the area that corresponds to the tricuspid valve isthmus. Then, if we want to recognize what are the structures that we need to recognize in the right atrium and the right ventricle. This is superior vena cava. This is inferior vena cava. Okay. This is right atrial appendage. This is superior vena cava. And here we have the area that corresponds to the pouch. This is the pulmonary artery. This is the right ventricle. Okay, this is the tricuspid valve. Okay, first point is that we have the orifice of the coronary sinus. Here, we're going to have the fossa ovalis. And all this area inside, we have the trabeculated area. And this is the area that corresponds to the terminal crest. The terminal crest, the orifice of the coronary sinus, this is the area of the cavotricuspid isthmus. The His bundle, here we have the compact AV node with the inferior extension, and the His bundle penetrated through the area of the membranous septum. This is the membranous septum. And we are going to have two parts of the membranous septum. This is this. One part is atrioventricular membranous septum, and this is the interventricular membranous septum. And this is the septal leaflet of the tricuspid valve. This is the annulus. Therefore, the annulus is dividing two components of the membranous septum, the atrio and the interventricular membranous septum. All these correspond to the area of the tendon of Todaro, and you are going to have here the terminal, the Eustachian valve, the Eustachian ridge, the Eustachian valve and the Eustachian ridge. And this is the cavo tricuspidismo. This is the vestibule, this is the inferior vena cava, and this is the pouch, the cavo tricuspidismus. We have here the pouch and the vestibule. This is the vestibule, the pouch, and the Eustachian valve or the Eustachian ridge. Therefore, this area of the AV junction is crucial because we have a slow pathway ablation here. This is the area of fast. Therefore, the AV junctions, and this is the result of different level of attachment between the tricuspid and mitral annulus. Let's go. Just a second. Okay, let's go to 1 4-chamber view. Here, you can see in this specimen, you can see the left atrium. This is the left atrium, this is the right atrium. And note the attachment of the, you can focus, the attachment of the septal leaflet of the tricuspid valve. This is the mitral valve. And please note that this is inferior in relation with the mitral valve. This is the left atrium, this is the right atrium. This is the inferior vena cava, and here you can see the area that corresponds to the vestibule of entrance to the tricuspid valve. This is the vestibule of entrance, this is the vestibule of entrance to the mitral valve. Please note that this is the attachment of the mitral valve, and this is the attachment of the tricuspid valve, inferior in relation with this. This is the muscular interventricular septum. This is the muscular interventricular septum. But if we go from here, this is the, here you can see the interatrial septum. We are going also to see in different specimens. And please note this area and this area of the interatrial septum. We are going to see that this is not septum. This is a fold of the left atrium and the right atrium, and this is the area that corresponds to the inferior pyramidal space. But in this specimen, please focus that this is the tricuspid valve and this is the mitral valve. If you see in this specimen, please focus. Okay, you can see that this is membranous, this is connective tissue, and this is the area here that connect the right atrium with the left ventricle. This is the so-called atrioventricular membranous septum. This is the area where the His bundle penetrate from the right atrium to the left atrium. And this is the area of the compact AV node. Then the atrioventricular and interventricular membranous septum are here. And if we go to this specimen, again, note again that this is the attachment of the tricuspid valve. The attachment of the tricuspid valve. This is the attachment of the mitral valve. And this is the atrioventricular membranous septum here. the atrioventricular membrane septum. And let's go to the left atrium, let's go to the right atrium. And if you see superior, not here, you see superior and you see inferior, if I perform transeptal punction from here to here, I'm going from the right to the left atrium. I'm going from the right to the left atrium. But please note, what is this? This is out of the heart. This is fibrofatty tissue. And please note what is this? We are here out of the heart. This is fibrofatty tissue. Can you see here the inferior pyramidal space? This is the area that corresponds to the inferior pyramidal space. Therefore, the only place to perform transeptal functions is the fossa ovalis, as you can see here. This is the only interatrial septum. This is the only through interatrial septum that this is the fossa ovalis. Superior and inferior, you can see that this is a fold of the left and the right atrium. Therefore, this is a very important anatomic determinant that we need to take into account, that this is the fossa ovalis. If you see in this specimen, you can see that this is the through fossa ovalis, the through interatrial septum. Please note here, by transilluminations, this is the fossa ovalis. This is the only interatrial septum. If we perform transeptal punction here, or if we perform transeptal punction here, we go out of the heart and inside the heart. Therefore, we are going to have tamponade. And here, you can see also, please note here, very interesting, the Chiari network. You can see here, the Chiari network. This is the inferior vena cava. Then, this is the right side aspect of the right atrium. Let's go again to this specimen and let's see in this specimen the anatomic landmark that we have shown in this drawing. First, the vestibule of entrance to the tricuspid valve, the vestibule of entrance to the tricuspid valve, the septal leaflet of the tricuspid valve. This is the tendinous cord, and this is the septal papillary muscle. Remember that we have septal anterior and posterior papillary muscle. This is the septal papillary muscle, septal leaflet of the tricuspid valve, triangle of Koch, limits of the triangle of Koch, vestibule, orifice of the coronary sinus, variable anatomy of the Tevesian valve. The Tevesian valve may create even some difficulties to introduce the catheter here because we have different anatomy of the Tevesian valve and we have different anatomy of the Eustachian valve, the Eustachian ridge, and the tendon of Toral. And this is the profile of the cavotricuspidismus. You know, this is the area where we perform bidirectional isthmus block in patients with common or isthmic atrial flutter. And they have a posterior barrier. This is macro-reentrant circles in the right atrium with an area of a slow conduction here in the low right atrium. And here we perform these bidirectional. This is like a quadrilateral area from lateral to more septally or more medial. And here the endocardial profile go from anterior, the vestibule, the pouch, and the Eustachian valve. And some heart, we can find different Eustachian ridge. And the Eustachian ridge may also create some anatomic difficulties when we perform this ablation. Also, please note the orifice, the area that corresponds to the fossa ovalis, and the terminal crest. This is the terminal crest here. and the anterior and posterior pectineal muscle. If we go to an open heart also here, if you have any comment or anything that you want to ask, please feel free to do that, because there the heart can be never ending. And here we can see, you see that this is the right atrium and sorry, the right ventricle. We have opened the right ventricle. You can see that this is the right atrial appendage. This is the right ventricle. In right anterior oblique, 45 degrees, more or less, projection, simulated projection. You can see that this is the right atrium and the right ventricle. Then let's open, remember all this area, and let's open, and we can see the area that corresponds to the right ventricle and the right atrium. What is this? This is the terminal crest. You can see the terminal crest. And what is this? The pectinate muscle. And this is the vestibule of entrance to the tricuspid valve. And this is the orifice, this is the fossa ovalis. And here you can see the orifice of the coronary sinus. Let's do transillumination just to facilitate finding. Here you can see that if we perform a transeptal punction from superior vena cava, this is the superior vena cava, we go with the catheter from superior plumb. This is the jump, and this is the fossa ovalis in this case. Please note its anatomic relation with the orifice of the coronary sinus and with the Eustachian valve and the Eustachian ridge. And if, as we have shown in the 4-chamber view of the specimen, it is very relevant that we should do the punction here in the fossa ovalis, because if we perform punction here or here or here, we go out of the heart. And this is right anterior oblique. This is right apex. Can you open more? Okay. Then this is the right ventricular apex. This is the his bundle recording site. This is the septal leaflet, and this is the orifice of the coronary sinus. And from superior in right anterior oblique projection, pluff, and we go here. Again, if you can see, if you see the pectinate muscle, please note the trabeculation, the variable anatomy of the trabeculation here. You can see that this is the terminal crest. Anterior, and posterior, the vestibule, all this area, you see here, this is the right atrial appendage, and this is the terminal crest. Please note the terminal crest here. How is the anatomy of the terminal crest? And this is crucial to understand how is the variable anatomy of this anterior and posterior pectinate muscle ending into the vestibule of the tricuspid valve. And now is the moment to see the 4 components of the right and the left atrium. We have 4 components. One component is the appendage. The appendage. The second component is the vestibule of entrance to the tricuspid valve. In the left atrium is the vestibule of entrance to the mitral valve. The third component is the intervenous component. This is the area between the superior and inferior vena cava. And the fourth component is the fossa ovalis. Therefore, the appendage, right etiet appendage, in the case of the left right etiet appendage, that this is the trabeculated area. Second is the vestibule of entrance to the tricuspid valve. 4 is the fossa ovalis. And third is the area that corresponds to the venous component. In the right side is the intercable venous component, and in the left side is the interpulmonary venous component. Anatomy landmark, anatomy regions in the right atrium. Anatomy landmark are the cavotricuspid isthmus. Please note here again, this is the isthmus. You can see that this is the orifice of the coronary sinus. This is the area that corresponds. Can you focus, please? Can you focus this region? Okay, perfect. You can see that this is the Tevesian valve. This is the ending of the pectinating muscle into the vestibule of the tricuspid valve. Here you can see that this is the area that corresponds to the pouch. This is the Eustachian valve, and this is the Eustachian ridge. Here you can see that this is the area that corresponds to the triangle of Koch. And this, from anterior to posterior, we have the vestibule, the smooth vestibule of the tricuspid valve. We have the pouch, and we have the Eustachian valve and the Eustachian ridge. Please note, the posterior and superior, we have the fossa ovalis. Then, the terminal crest, you see, from superior, the terminal crest, here, from C-form, from superior to inferior, this is simulated right anterior projection. It has been noted. The terminal crest, therefore, if this is from superior, this area is the sinus-nodal region. This is the right etiet appendix. This is sinus-nodal regions. If you go to the sinus-nodal regions here, you can see that this is in close anatomic relation with the terminal crest. This is the area of the sinus-nodal regions that if you go here and go here, you see that this is the terminal crest. Terminal crest. Then let's go again here, and you can see all the area of the pectinating muscle. And the terminal crest is a very important and relevant area. This is the superior vena cava. You can see that this is the superior vena cava. All this area of the terminal crest is also an important area that we need to take in our mind. How is this variability of the pectinating muscle? Because some atrial tachycardia may arise in these regions. Even when we are mapping the area of the superior, let's go here, okay, the superior vena cava here, and we have here, okay, again, we have the terminal crest inside, and this is the area where we map the so-called sinus-nodal reentrant tachycardia or inappropriate sinus tachycardia. Then, if the sinus node is here, and we are mapping here, please note how are the anatomy determinant. This is one. This is the thickness of the terminal crest in between the sinus-nodal region and the endocardial aspect of the right atrium. And also, it has been removed here in this specimen, but please note that the phrenic nerve is in these positions. If we go, if we go here in this specimen epicardially, this is the superior vena cava, and this is the sinonodal regions. And this is the area that we need to take into account, that the phrenic nerve is here, and the close anatomic relation of the phrenic nerve when we are doing mapping inside the endocardial aspect of the right superior pulmonary vein or the superior vena cava. We need, even with the cryoablation, we need to take into account how is this close anatomic proximity. Then, moving to the right ventricle, we should consider first that we have one anatomic landmark, that this is the septomarginal trabeculation. And this is the moderated band. Moderated band connecting with the anterior papillary muscle. Here we have the medial papillary muscle in the right ventricular outflow tract. Medial papillary muscle, septomarginal trabeculation, infundibular attachment of the septomarginal trabeculation. Here, moderated band, infundibular, and here we have the septoparietal trabeculation, septomarginal trabeculation, septoparietal trabeculation, infundibular attachment, pulmonary valve, and remember that this is the aorta protruding in this area, that this is the supraventricular crest. The supraventricular crest in anatomic relationship with the membranous septum, with the septoparietal trabeculation of the right ventricle, and with the pulmonary valve. Here, we can see an important anatomic determinant when we want to understand how is the anatomic relation between the right ventricular outflow tract and the left ventricular outflow tract. Please note that the aorta is in close anatomic relation with the membranous septum, and we are going to see how the membranous septum appears between the non-coronary sinus here on the right. And this membranous septum is going to be crucial to understand also how is the arrangement of the left bundle branch in the subaortic outflow tract. Because here we have the compact epinode, the his bundle penetrating the membranous septum. Here, go. This is the right bundle branch in relation with the septal papillary muscle. This is the septal papillary muscle. Septal papillary muscle. And you can see how it's going to the moderated band. Therefore, this is the right bundle branch. The right bundle branch in close anatomic relation with the septal papillary muscle, septomarginal trabeculation, moderated band. And all these anatomic relations we need to take into the right ventricular outflow tract. If we see in the specimen here, you can see that this is the supraventricular crest, and this is the aorta. I am introducing my finger in the aorta, and this is the fold, the ventricular infundibular fold. Therefore, these anatomic regions of the right ventricular outflow tract is in close anatomic relation with the aorta. But you can see how is the different orientation of the aorta and the pulmonary trunk, just to understand the QRS complex axis during the VTE in this area. Please note how is the orientation of the pulmonary trunk in relation, and how is this anatomic regions. This is the subaortic outflow tract, right ventricular outflow tract. And here you can see the large septomarginal trabeculations. And here you can see the attachment of the septal papillary muscle. And this is the conus. This is the right ventricular outflow tract. This is the infundibulum. And the main anatomic determinant and the main anatomic landmark that we should take into account is the presence of this supraventricular crest. Remember, the His bundle is penetrating here and go here through the septal papillary muscle, the right bundle. This is the septal marginal trabeculation with its infundibular attachment, and this is parietal. And you can see all these that correspond to the septoparietal trabeculation. If we go to this specimen, note that this is the pulmonary trunk, and you can see the independent attachment of the leaflet of the pulmonary valve, and this is not a through annulus as we see when we speak about the mitral and tricuspid annulus. This is not a through annulus, this is a virtual annulus, and for intervention cardiology is very relevant in the aorta. All the anatomy of this virtual annulus in relation with the His bundle, just to avoid during percutaneous implantation of TAVI, just to avoid a left bundle brand damage. And please note that this is the pulmonary valve. And if we go inside the pulmonary valve, here, we are going to see the presence of muscle here. Therefore, we have muscle above the pulmonary valve, muscle above the pulmonary valve. And here, we have connective tissue. Therefore, we have ventricular muscle incorporated within the sinus, and we have artery incorporating within the ventricle. Then we have in the commissaire, we have this, you can see this connective tissue. And here you can see this connective tissue. Therefore, we have muscle inside, connective tissue, muscle inside, and connective tissue. Therefore, this is one important anatomic landmark that we need to take into account when we are mapping the right ventricular outflow tract. The aorta is here. I introduce in my finger the aorta, and you can see that this is the supraventricular crest. Here, this is the area of the supraventricular crest, and it has been opened like a book. Okay, this is the ventricle. Okay, if therefore this is parietal. This is parietal. If we open, look, the septoparietal, the left and right septoparietal trabeculation. These are the septoparietal trabeculation, and here we have the septomarginal trabeculation. Please note here now how the supraventricular crest belong to both the right atrial, the right parietal atrial wall, and this is the right ventricular outflow tract. Therefore, this is the ventricular infundibular fold that is separating in between the outlet and the inlet. This is the septal leaflet of the tricuspid valve. This is anterior. And this is the septal leaflet of the tricuspid valve. In this septal leaflet, the tricuspid valve, you can see, there's note here, you can see septum, here you can see the tendon cord, and this is septum. You can see that this is septum. And all these areas are subpulmonary located, and these are the septoparietal trabeculation. Please note here the presence of this septoparietal trabeculation. These are an important anatomic determinant because these may create variability, anatomic variability, because there are a marked variability of this septomarginal trabeculation, and the septoparietal trabeculation. Please note this septopapillary muscle, and please note this. Here you can see. This is the area where the right bundle branch appear. Here through this septomarginal, and the moderated band that has been destroyed in this case to connect here. You can see it's connecting here. Okay, and this is the area of the right bundle. This is the apical component. Then, to understand the relationship between the right ventricular outflow tract and left ventricular outflow tract, please note that this is the supraventricular crest. And if we go to both components of the supraventricular crest here, all this area is superior and paraseptal. This is not septal. Remember that the only septum that we have in the right atrium is the fossa ovalis, and the membranous septum. This is septum, the membranous septum. Therefore, when we are mapping in this area of the right AV junction, this is the orifice of the coronary sinus, we have this inferior area, and this is not septal. We should use the term inferior paraseptal region. This is the so-called mid-septal region, but this is not septal because a punction here is, as I have shown in this specimen, a punction here, we go to the inferior pyramidal space. Therefore, this is not septum. This is the only septum. Remember that this is the area of the triangle of Koch. Is one of the sides of the inferior pyramidal space. Then, if I perform septal punction here, this is septal leaflet again, then of the triangle of Koch, this is paraseptal region. The only septum is here, that this is the His bundle penetrating. Therefore, we can distinguish in this area two types of ventricular insection of the accessory pathway. This is for electrophysiologists. One is those that are penetrating the His bundle, the membranous septum, the ventricular insertion penetrating here, and these are through septal accessory pathway, and all that are in this area that in fact are parahesian accessory pathway because the His is here, and we are very close to the parahesian region, and this is superior paraseptal, that this is crystal. This is the supraventricular crest. Therefore, parahesian region, let me see if I have the possibility to introduce here. Okay, you can see the membranous septum. You can see an interventricular and atrioventricular membranous septum. The light is in the left. The light is here in this area. The light is in the left ventricular outflow tract, and here you can see that the His bundle penetrated here. Therefore, inferior paraseptal region, right and left inferior paraseptal, mid paraseptal regions, because this is, as I have shown in the fourth chamber, this is not septum, and this is septum. The accessory pathway penetrating the membranous septum for the ventricular insertion here. This is the through septal that are parahesian, as was described by Michel Iseguer. You know that this is parahesian accessory pathway, and this is through septal, and here we have crystal accessory pathway. Therefore, all these are parahesian region. Again, let's go to the left side. If we go to the left side, and here you can see the left atrium and the left ventricle. This is the fossa ovalis. This is the left side aspect of the fossa ovalis. But please note the smooth wallet, because the venous component is the major part of the left atrium. That you can see that this is the mitral valve, or the mitral valve. This is here, you can see the fossa ovalis. This is like a pocket. You can see a pocket of the fossa ovalis, because the punction, in fact, is in this area. As you can see what is the fossa ovalis. We should take into account the presence in some patient of this pocket here, you can see. Okay, this is the left atrium, and note the septal leaflet, the anterior leaflet and the mural leaflet, and let's go to the papillary muscle. This is anterior. This is anterior. Therefore, this is, you can see that we need to identify two papillary muscles, one anterolateral and the second posterior and medial. And here you can see in the left side, you can see the complex anatomy of the papillary muscle. Please note that we are speaking sometimes of one papillary muscle, and you can see how is the complexity of this papillary muscle. If we focus here, this is the apical component of the left ventricle, epicardium, endocardium, and papillary muscle. And let's go here to the left ventricle. Here you can see that this is the left atrium, and you can see in this specimen, let's see in this specimen, the papillary muscle. Please note the variable anatomy of this papillary muscle, and we are going to see the mitral-aortic continuity. Let's show here the left ventricular outflow tract. In this specimen, look that this is short axis. We are going to review. This is short axis, okay? And this is anterior. You can focus. This is anterior. This is posterior. This is the aorta. This is the pulmonary trunk. And note, let's open here, the area that corresponds to the inferior pyramidal space, and this is the orifice of the coronary sinus. Therefore, all this area, if this is the orifice of this area, this is the septal leaflet of the tricuspid valve, and this is the area where the His bundle penetrates. If I focus here, we are going to see here the membranous septum. Therefore, this is right AV junctions. This is septal leaflet of the tricuspid valve. This is the vestibule. This is the orifice of the coronary sinus. This is the triangle of Koch on the solar axis. This is the septum. This is anterior, and this is posterior. Okay, leaflet. If we go again here, if we go to the mitral annulus, you can see that this is the mitral-aortic continuity. This is the aorta. This is the aortic leaflet, and this is the mural leaflet. And let's go here, them, menos focus. Okay, the area that corresponds to the inferior pyramidal space. This is the base of the heart. With this position, this is the base of the heart. You can see the posterior interventricular groove. This is the coronary sinus. Coronary sinus surrounding the mitral annulus, and you can see anteriorly the left atrial appendage, and this is the right atrial appendage. Please note the anatomic relation. Then, in visual axis, we see this is these positions and this position. This is the sections. Okay, and let's go again to the solar axis and note that the narrow mouth marks the junction between the left atrial appendage and the smooth or the venous component of the left atrium. This is the left atrium. And here, the area that corresponds to the mitral-aortic continuity. Then, what are the anatomic relations between the aorta, the mitral-aortic continuity, the pulmonary artery, and the membranous, and the membranous septum, as you can see here. Let's open the aorta. Here, let's open the aorta. I'm going to open the aorta. And this is the right ventricle, the left ventricular outflow tract. In the left ventricular outflow tract, we are going to see several components. Remember that we distinguish the left fibrous trigon, right fibrous trigon, mitral-aortic continuity, membranous septum with two components of the membranous septum that are the atrioventricular and the interventricular component of the membranous septum. Then, this is pulmonary valve. You can see the pulmonary valve, and note the anatomic relation with the aorta. I'm going to close. Pulmonary valve and the aorta. Okay, then let's open, because this is for electrophysiologists, the anatomic relation of the right and the left ventricular tract is crucial. But for cardiology also, just to see how is this orientation. And you can see, open, I'm going to open again. And here, you can see, this is like a book. Then, this is posterior, this is non, and this is right. You can see here the coronary artery. Okay, this is, you can see the right coronary artery. This is right, this is non, and this is left. This is left. Then, if this is left, this is the left fibrous trigon. This is the left fibrous trigon. And this is the right fibrous trigon. And this is the mitral-aortic continuity. If this is the mitral-aortic continuity, then this is the aortic leaflet of the mitral valve. You can see this is the leaflet, and you can see in the other way, the other leaflet here. Then this is the aortic leaflet. Aortic leaflet, commissure, commissure. Then, where are the membranous septum, the interventricular membranous septum? In between the none and the right. In between the none and the right. This is the fibrous trigon. This is the mitral aortic and the left fibron, the right. And here, and now I am going to do the same, but from the right atrium. And here you can see the membranous septum. Please note by transillumination that this is the area that corresponds to the membranous septum, and here you can see the right fibrous trigon, all the area of the right fibrous trigon. Then this is the area where the His bundle penetrates from the right side, because the right side is here. You can see that the right side is here. And then if we penetrate, if we see the area of the membranous septum, this is the area where is the left bundle branch. This is the left bundle branch. The His bundle penetrates through this area, and this is the left bundle branch. This is an important area that cardiology need to identify. If you remember the supraventricular crest in between the right atrium and the inlet and the outlet, please note the mitral-aortic continuity. In the left ventricle, there a continuity between the outlet and the inlet, and this continuity between the outlet and the inlet is very important to recognize. All this structure of the left and the right fibrous trigon and the mitral-aortic continuity. Here and here, we are going to identify this area that corresponds to the left bundle branch. This is the so-called inferoseptal recess. The inferoseptal recess in between the aortic leaflet of the mitral valve and the area that corresponds to the ventricular septum. And this is also an important area that, with this anatomic variability in this area, may create different position and rotation of the aortic valve that is crucial for interventional cardiology. Let's go now to the inferior aspect, and let's see here. This is a beautiful view. In this beautiful view, you can see the left ventricle and the right ventricle. You can see how is the morphology of the right ventricle, thicker, thinner, and trabeculated right ventricle. And here you can see the coronary artery descending into the interventricular septum. Here you can see how big we have the section, and you can see the right atrial appendage. Sorry, the left atrial appendage here. In this position, you can see how is over the groove, okay? And note that here you can focus. One and mural and anterior and septal, aortic leaflet, and mural. Then you can see the mural, the aortic, and here you see again the left ventricle overflow, the mitral-aortic continuity, and here you can see the membranous septum. I close again, and let's go to the right ventricle. And in the right ventricle, you can see the pulmonary valve, Here, see the pulmonary valve, and the area that corresponds to the septomarginal trabeculation and septoparietal trabeculation. And here you can see the leaflet of the tricuspid valve. All this area is the right ventricular outflow tract. And in this right ventricular outflow tract, please note that this is the septoparietal trabeculation. Here, you can see the septoparietal trabeculation, the septomarginal trabeculations, and the area that corresponds to the infundibular outflow tract. Here, we have infundibulum, but they are not infundibulum in the left side because the mitral-aortic continuity. And here, if we go again to see the anatomic relation between the right and the left ventricular outflow tract, please note these positions. This is, here you can see the aorta. This is the left atrium. You can see the coronary sinus here, surrounding the annulus of the left atrium. And again, my finger, you can see the aorta and you can see the pulmonary. Please note, first point is the axis. How is the orientation? You can see the axis, this orientation and this orientation. Then, let's open, and you know that the node is posterior, okay? Then the node is posterior, and the node is this one. The node is this one. That's right. And this is the left, and this is the right. First point, you can see the anatomic relation of the right in relation with the pulmonary trunk and the right ventricular outflow tract. My finger here is in the right ventricular outflow tract. Then let's go again, and please note here, if we focus, look, the right ventricular outflow tract, and look this thickness. Then this is superior, and here you can see the aorta. If I want to be from the left ventricular outflow tract inside the left ventricular or in contact with this is not the way. Look, the muscle. I need to be inside the right to be here, because this is the only way that is thinner. Then, what are the anatomic relationships between the right ventricle and the left ventricle? First, how is the axis? How is the orientation? This is anterior, this is posterior. And how is the anatomic relation of the node and the right? And here you can see that this is the right. And how is its close anatomic relation with this area? I want to be here. I need to be from inside the right coronary cusp. Second, and finally, because the time is okay, let's go to this area. We are going to see in this specimen, we are going to see this area of this is for electrophysiology. You can see the left atrial appendage, okay, and this is the left ventricular summit. This is the area that corresponds to the myocardial vein, the descending artery, the circumflex artery. Okay, let's go in this specimen. If you see this specimen, this is the left atrium. We have not been removing the epicardium, and this is the area that corresponds to the left ventricular submit. You can see the left ventricular submit. And if we go here, let's go again and open. Then this is the left ventricular submit, the area that corresponds to the left ventricular submit. Please note that this is fibrofatty tissue and this is the coronary artery. And please focus and how approach the left ventricular submit. You can see here, this is the endocardium. This is muscle. But all this is fibrofatty tissue. And here we have the coronary artery and the coronary venous system. Note the proximity of these, the left coronary cusp. Therefore, these are anatomic landmark, the fibrofatty tissue, the coronary artery, and the close anatomic proximity with this, but also with the left atrial appendage. Some groups are mapping from the tip of the left atrial appendage the area that corresponds to the submit. This is the left atrial appendage, and this is the submit. Okay, we can map this area using the tip of the left atrial appendage and take into account also the proximity of the coronary cusp. And if we go, if this has been closed, you see, you can see here the area that corresponds to the anterior descending artery. Therefore, the proximity of the appendage, the proximity of the coronary cusp, how is the fibrofatty tissue, and the coronary artery and vein. And finally, let's go to the left atrium. 5 minutes for the left atrium. ¿Tenemos 5 minutos? Okay. Epicardially and endocardially. Okay. Then we have seen the Bachmann bundle. We have seen the Bachmann bundle in relation with the transverse sinus of pericardium. And we have seen the left word extension and the right word extension of the Bachmann bundle surrounding the left atrial appendage. And now, in this specimen, we can see the left atrium, and we can see the Bachmann bundle connecting. This is mitral annulus, and tricuspid annulus. Okay, and you can focus. Superior vena cava, right superior pulmonary vein. Please note the myocardial extension over the wall of the superior vena cava. Far field potential from the right superior to the superior vena cava, and isolation of the venous tissue extending over the wall. Bachmann bundle extending through the right wall extension, terminal crest endocardially, right atrial appendage. Left wall surrounding the appendage, the right atrial appendage. This area, the area that corresponds to the Bachmann bundle. Please note, superiorly, the subepicardial myocardial fibers. This is, you can see the tissue, you can see the fibers. Can you focus? This is the so-called septopulmonary bundle. You can see the septopulmonary bundle. For electrophysiology, it is crucial to learn about the Bachmann bundle and septopulmonary bundle epicardially located. These are the myocardial sleeve extending. This is venous, but please note the myocardial sleeve. Right superior, right inferior, and you can surround in this area. This area, this is the epicardial aspect of the ridge. And we have shown this in this specimen that you can see the components of the left atrium. This is epicardially located. This is the left superior and the left inferior pulmonary vein. This is the leftward extension of the Bachmann bundle. The appendage, this is the main lobe of the appendage surrounding the Bachmann bundle, the fibers of the appendage. You can see here the fibers. And this is the AV groove. You can see the coronary artery and the AV groove, the left AV groove. And you can see now that this is the ventricle, okay? And please note, this is the mitral valve. This is the mitral valve. You can see the left ventricle. And let's focus, please. Let's focus. One important anatomic determinant. Please note, thinner, thicker, thicker, thicker. Non-uniform myocardial content of the left atrium. This is crucial to understand. We need to take that into account. Here, you can see the pulmonary vein, superior and inferior pulmonary vein, and you can see the ridge between superior to inferior, between anterior to posterior, and this is the orifice of the left atrial appendage. A narrow mouth marks the junction between the venous component and the appendage. This is the ridge, and all this area correspond to the vestibule of entrance to the tricuspid valve. From here to here, this is the so-called mitral isthmus. Therefore, the anatomy of the left atrium with the four components that are the interpulmonary venous component, the appendage, the fossa ovale that has been removed in this specimen because this is the area that we just to visualize the lateral wall. This is the lateral wall, and the more important endocardial aspect that this is there. You can see here that this is not a through ridge. This is a fold of the lateral wall of the left atrium. And here we have not removed the endocardium, but if we can see here in this specimen, here we can see the subendocardial myocardial fibers of the left atrium. You can see the orientation of the fibers, and we are going to distinguish here. I can show you, but without dissections. Here we have the three part of the so-called septoatrial bundle. If we go to the figure, then we need to understand what is the Bachmann bundle. We need to understand what is the septopulmonary bundle, and we need to understand what is the septoatrial bundle. The septopulmonary bundle, epi, septoatrial bundle, endo. Septopulmonary epi, you know, the Bachmann bundle connecting the right atrium and the left atrium epi. Then the septopulmonary bundle is this one. Septopulmonary bundle is this one, the Bachmann bundle, and endocardially we have the septoatrial bundle. And if we go to the drawing just to visualize the area that corresponds to the septum, if we have here, and we have the orifice, the left atrial appendage, and this is the orifice of the left superior pulmonary vein, here we have one layer of the bundle through the vestibule of the mitral valve. And here we have a second layer inside the left atrial appendage, and the third layer go through the fossa ovalis. Then we have three layers of the septoatrial bundle, and these go inside the orifice of the left atrial appendage, and this is the ridge. Therefore, the ridge here, epicardially, endocardially, is the septoatrial bundle go inside the orifice of the appendage and go to the septum. And here, epicardially is the leftward extension of the Bachmann bundle. Therefore, the ridge have, if we go from here, and this is the left atrial appendage, the left superior pulmonary vein. We have, this is endo, this is the circumflex artery. Here we have, for example, the phrenic nerve. Okay, this is the landing zone of the left atrial appendage, and the ridge. Here we have epicardially the Marshall vein or ligament of Marshall, and we have one artery, small artery, the left intermediate artery, that is a branch of the circumflex artery. This is epicardially, but endocardially is the septoatrial bundle, and epicardially, this is the leftward extension of the Bachmann bundle. Therefore, the ridge, it is a very crucial anatomic area that epicardially we have the leftward extension of the Bachmann bundle. Here we have, it has been removed. We have the Marshall vein, we have the left intermediate artery branch of the circumflex artery, and endocardially we have the septoatrial bundle. Therefore, the ridge is much more complex than the simple protuberance of the endocardial aspect of the left atrium or an infold of the lateral wall of the left atrium. This is also the complex anatomic relation with artery, with vein, because don't forget that here also we have postganglionic fibers, postganglionic sympathetic fibers, and ganglionic parasympathetic fibers and ganglia. Therefore, all this is the area of the epicardial aspect of the rib that is crucial. Okay, I think that my time is close, and si quieres ponerme.
Okay. Thank you very much, Professor Cabrera. Are you done, or do you need a few more minutes?
Yes.
Okay. So thank you very much. It was really impressive the way you presented anatomy and the way you related it to cardiac electrophysiology and above it, or to related it to interventional electrophysiology and made cautious and particular structure and show how finally cardiac chambers are not chambers but very complex entities with many structure and very complex relationships between each other. So I guess there might be some questions. So it was a really sophisticated presentation, but you noticed that we recorded it, and of course you will have access to the recording as long as you need it. So do you have any questions you'd like to ask to Professor Cabrera?
Okay, I think that what we need to take in our mind is that just to see what are the region of interest in the right, in the left, in the right ventricle, in the left ventricle, region of interest in the right atrium. For example, cavo-tricuspidismus, triangle of Koch, the region of the synod node, anatomic landmark in the right atrium, orifice of the coronary sinus, terminal crest, membranous septum, area where the His bundle penetrates. Left side, for example, the regions of the mitral isthmus, the anatomic landmark of the ridge, and the right ventricle, septomarginal trabeculation, septoparietal trabeculation, supraventricular crest, moderated band. The left side, mitral-aortic continuity, right and left fibrous trigon, and how are the connection between the right and the left ventricular tract. But don't forget that now we are in these 2 hours, we have seen the gross morphological feature of the human heart. But now we have many imaging tools like CT scan, magnetic resonance imaging, navigation system, that may us facilitate to understand the gross morphology and how are the attitudinal orientation, how are the anatomy. We need also to understand architecture. We need to move to architecture because now we know the relevance of a scar, not only for ischemic, for example, VT, but also, for example, for left atrium. We need to move to architecture. And for example, architecture is not only endocardium, myocardium, or pericardium or epicardium. We need to know that we have cardiomyocytes and interstitial space. And in the interstitial space, we have also cellular component. And these cellular component are fibroblasts that may move to myofibroblast. And the number of fibroblasts is 60% in contrast with the number of cardiomyocytes. And also the extracellular matrix, collagen fibers. Therefore, architecture is not the future. Architecture is the present. We have no time just to show histological section or a slide in this. We will do in other occasion, but I think that we need to understand gross morphology, but also architecture.
I think we have one question for you.
Can you hear me?
Yeah. Yes.
Hi, Professor Cabrera. It was an impressive lecture. I'm just curious about pulmonary vein isolation, and I don't know if it's possible to see in the gross anatomy any difference exactly where the rings start, so the rings of the pulmonary veins. So I'm just curious if it's possible to see something in the tissue.
Okay.
Thanks.
Okay. Here you can see the left atrium, and let's try to put in attitudinal orientation. Okay. Attitudinal orientation. This is anterior. Okay, and this is posterior. You can see that the left superior and the right superior are anteriorly orientated and are superior in relation with the right inferior and left inferior that are posteriorly orientated. Okay, You can see that this is anterior, and note the myocardial tissue here. In this specimen, you can see the more important anatomic variability of the ending of the pulmonary vein. That is the common ending for both right superior and left superior and left inferior pulmonary vein. This is the common trunk, common ending. Here you can see the right superior pulmonary vein, and this is the the superior vena cava. Here you can see that these are anteriorly orientated, and this is posterior, and this is superior in relation with this. Endocardially, when you go to the endocardial aspect, and this is in this specimen, you can see the orifice, the right superior and the right atrial appendage. But when you go to understand how is this anatomic relationship, here you can see that this is the orifice of the pulmonary of the left atrial appendage. This is the left superior and the left inferior, and this is the ridge. Okay, then sometimes this is superior, but sometimes this is more medial or more inferior in relation with the left atrial appendage. Endocardially, we have variability in the position of the left superior and the left inferior in relation with the left atrial appendage. Then also the thickness of this ridge can be thicker, can be thinner, or can be, okay, this is the ridge, okay, because it's not depending the muscle, it's depending how is the fold in between, okay. Then endocardially, the position of the left superior and the left inferior is variable in relation with the left atrial appendage, and usually the left superior pulmonary vein is at superior level in relation with the orifice of the left atrial appendage. You know that the narrow mouth marks the junction between the venous component and the orifice, but sometimes we can have here also extra appendicular pectinated muscle, and I think this is crucial. Then we are now that we are using, podemos poner la imagen. Now that we are using a navigation system, then we are able to see how is this variable endocardial topography of the orifice of the left superior and inferior pulmonary vein in relation with the orifice of the left atrial appendage. But remember, and I want to focus again, the myocardial content epicardially and endocardially, to understand how is this Bachmann bundle, how is this septopulmonary bundle, how is the septoatrial bundle, is crucial. It's crucial to understand what are we doing during ablation of the pulmonary vein foci for atrial fibrillation, because I have shown that the superior vena cava, the myocardial tissue extends over the superior vena cava. Sometimes we need to isolate the superior vena cava because some extra pulmonary foci arise from the superior vena cava, from the coronary sinus, the area of the coronary sinus, because the coronary sinus may also show myocardial sleeve or even surrounding the fossa ovalis. We need also think that the pulmonary vein are not the only foci that sometimes we need to ablate. The extra pulmonary vein foci, even the regions of the ligament of Marshall that I have shown previously. You know that the group of Valderrama described ablation in this area of the ligament of Marshall. Therefore, not only pulmonary vein here, you can see the orientations and the area of the Bachmann bundle. Okay, then are you happy with the answer?
I guess so. Well, Professor Cabrera, thank you very much. We have to now put the end to this wonderful presentation and demonstration. And be sure that we will contact you next year, I think.
Please
Okay.
give my regard to Melesa, to Michelle Iseguet, please.
I will do it. Thank you very much again. Have a nice day. Bye.
Bye-bye.